Hello friends, welcome back to Shiji classes, and today we are going to discuss potassium sparing diuretics. Aldosterone antagonist and renal epithelial sodium channel inhibitors indirectly conserve potassium while inducing mild natriuresis and hence are called the potassium sparing diuretics. They are also known as adjunctive diuretics. First, aldosterone antagonist. It includes two drugs, spironolactone and eplerenone. First, we will discuss spironolactone. It is synthetic steroid and chemically related to aldosterone. Next, mechanism of action. First of all, you have to understand what normally aldosterone does in our body. Here is the aldosterone. Step 1. Aldosterone enters late DT and CD cells through the basolateral membrane. Then, step 2. Aldosterone binds to specific mineralocorticoid receptor in the cytoplasm. Here is the mineralocorticoid receptor and both hormone receptor complex is formed. Then step 3. Hormone receptor complex translocates to the nucleus. Here translocation to the nucleus is seen. Step 4. It promotes gene-mediated mRNA synthesis. Here is the mRNA. Step 5. The mRNA then directs synthesis of aldosterone-induced proteins. The AIPs increases ATP, increases the expression of sodium channel on the luminal membrane, and increases the de novo synthesis of the sodium channels. The AIPs also increases the expression of sodium-potassium ATPase on the basolateral membrane. It also promotes the de novo synthesis of sodium-potassium ATPase. Hence, the net effect is increase in sodium reabsorption but not accompanied by chloride anions, and hence it creates negative transepithelial potential difference. Thus, potassium secretion and H+ secretion happens. Now, what does spironolactone do? It is a competitive antagonist and binds to mineralocorticoid receptor, thus prevents the aldosterone action and produces opposite effects. Spironolactone has no effect on sodium and potassium transport in the absence of aldosterone. Thus, spironolactone increases sodium excretion and decreases potassium excretion. Then, spironolactone is a mild diuretic because majority of sodium has already been reabsorbed proximal to its site of action. Mainly, spironolactone antagonizes the potassium loss. Resistance to other diuretics that develops due to secondary hyperaldosteronism can be reversed. Potassium retaining action develops over 3 to 4 days. It also increases calcium excretion by a direct action on the renal tubules. Other actions. It also blocks the progesterone and androgen receptors, so it enhances testosterone clearance or its peripheral conversion to estradiol. It also blocks ether A-GO related gene channel in myocardium that leads to arrhythmia. Pharmacokinetics. The oral availability of spironolactone is 75%. It is highly bound to plasma protein, extensively metabolized in the liver, forms an active metabolite known as candrenone. The dose is 25 to 50 mg BD, that is twice a day. T-half of spironolactone is 1 to 2 hours and of its active metabolite, that is candrenone, is 18 hours. Uses. First, to counteract the potassium loss due to thiazide or loop diuretics. Second, in the edema, mainly cirrhotic and nephrotic edema in which the aldosterone levels are high, and it is frequently added to thiazides or loop diuretics in the treatment of ascites due to cirrhosis of the liver. Spironolactone is particularly employed in the refractory edema. Third, hypertension. It is used to augment a thiazide in the treatment of resistant hypertension. Further, it has the potential to attenuate hypertension-related renal fibrosis and ventricular hypertrophy. Fourth, heart failure. As additional drug in moderate to severe CHF, that is chronic heart failure, because it blocks the effect of aldosterone. It serves to retard the disease progression and lowers the mortality and also prevents ventricular remodeling. Fifth, primary hyperaldosteronism, that is Cone syndrome. Now, we will see some drug-drug interactions. First, spironolactone with potassium supplements. Dangerous hyperkalemia can occur. Spironolactone with digoxin. Digoxin toxicity enhances. Spironolactone with ACE inhibitor or ARBs, hyperkalemia occurs. Spironolactone with aspirin, as aspirin blocks the spironolactone action by inhibiting the tubular secretion of its active metabolite, that is candrenone, and hence decreases its action. Adverse effects: drowsiness, ataxia, mental confusion, epigastric distress and loose motions, that is diarrhea, gynecomastia, erectile dysfunction and loss of libido in men, breast tenderness or menstrual irregularities in the woman, risk of acidosis particularly in the cirrhotics. Peptic ulcer may be aggravated, hence it is contraindicated in ulcer patients. And hyperkalemia is the risk, especially if renal function is inadequate or in the presence of renal disease. Then we will talk about the second aldosterone antagonist drug, that is eplerenone. It is newer and more selective aldosterone antagonist. It has much lower affinity for androgen and progesterone receptor, and hence the side effects are less. Thus it makes the eplerenone suitable for the long-term use. Next, pharmacokinetics. Oral bioavailability is 69%. Inactivated in the liver by CYP3A4. Inhibitors of it increases the blood level of eplerenone. The inhibitors are clarithromycin and itraconazole. Inducers will decreases its efficacy. The example are carbamazepine or rifampicin. They are excreted in urine and feces. In the urine, 2/3 and in the feces 1/3. Better tolerability profile. Dose is 25 to 50 mg BD, that is twice a day. Uses: first, moderate to severe CHF. Second, hypertension. Third, post-infarction left ventricular dysfunction. Fourth, can be used as an alternative to spironolactone. The adverse effects are risk of hyperkalemia and GIT side effects are like the spironolactone, but less likely to produce the hormonal disturbances such as gynecomastia, impotence or menstrual irregularities. After aldosterone antagonist, we have next potassium sparing diuretic, that are renal epithelial sodium channel inhibitors. Triamterene and amiloride are the drugs. They are non-steroidal with organic basis. The main effect is to decrease the potassium excretion and a small increase in sodium excretion. Calcium and magnesium and excretion is also reduced. Its action is independent of the aldosterone. Site of action is late DT and CD cells. Here are the renal epithelial sodium channel. It takes the sodium inside the cell and partially depolarizes the luminal membrane as it is not accompanied by chloride or bicarbonate ion. Thus it creates negative transepithelial potential difference, that is minus 15 millivolt. It does two things in the cell. It promotes or activates the potassium excretion from the cell to the lumen, and also the intercalated cells of CD possesses an ATP driven H plus pump which secretes H plus ion into the lumen is also activated through this negative transepithelial potential difference. Amiloride inhibits the renal epithelial sodium channel and inhibit the action. Amiloride inhibits renal epithelial sodium channel. It decreases the lumen negative potential and hence decreases H plus secretion that can predispose to acidosis, decreases potassium secretion and increases sodium excretion. Pharmacokinetics. Here is of triamterene and here is of amiloride. First, triamterene. 50 to 100 mg dose is given, whereas of amiloride 5 to 10 mg dose is given once a day or twice a day. Hence, amiloride is 10 times more potent than triamterene. Oral absorption. Here incomplete and here 1/4. Plasma protein binding. Partly and not bound to plasma protein. Metabolism. Largely metabolized in the liver to an active metabolite. Amiloride is not metabolized. It is excreted unchanged in the urine. T-half. 4 hour, 20 hour. Side effects: nausea, dizziness, muscle cramps, rise in blood urea, impaired glucose tolerance, and photosensitivity. In amiloride, the side effects are nausea, diarrhea, and headache. Amiloride decreases calcium and magnesium excretion. It also increases the urate excretion. Both amiloride and the triamterene are the low efficacy diuretics. Next, uses. First, they are used in conjunction with thiazide or loop diuretics for the treatment of hypertension. Combination therapy increases the diuretic and antihypertensive effects, whereas also it prevents the hypokalemia. Second, amiloride is used for the treatment of lithium-induced nephrogenic diabetes insipidus, as it blocks the entry of lithium through the sodium channels in the CD cells. Third, amiloride aerosol in aerosol form improves the mucociliary clearance in the patients with cystic fibrosis. Next, adverse effects. Hyperkalemia. It is the most important and high risk adverse effect. It is not given in the patients with renal insufficiency or those patients who are taking potassium supplements. Nausea, vomiting and diarrhea can be there. Headache, dizziness or muscle cramps can be present. Thanks for watching my video. If you found it helpful, then please like, share and subscribe. And if you have any query, then you can ask in the comment section.